Good afternoon, everyone, for those of you in Eastern Standard Time. Hello, my name is Joni Harvey, and I'm excited to welcome you to today's EMS Focus webinar. Thank you for joining us. We have a really informative session for everybody planned today, so we're going to dive right in. Is it making sure there we go. So just an overview of the EMS Focus webinar for today. As you likely know, since you're here, the EMS Focus webinar series is designed to bring you quarterly updates and insights about the EMS system improvement. The webinars feature topics from NHTSA and the Office of EMS, and along with contributors from our federal partners and our Federal Interagency Committee on EMS, FICOMS. We address a variety of important topics on here, and I encourage you to register for future webinars if you have not done so already. And don't forget to sign up for emails, notifications from ems.gov to stay informed on everything that we're talking about today. Let me try to remember to keep the slides moving here. For Zoom, so just some housekeeping, just to cover a quick couple items here. Please use the Q&A button on your Zoom control panel to submit any questions throughout the session. We will address them during the last 15 minutes of the webinar, but feel free to submit questions as they come to mind. That way you're not forgetting them and trying to remember them later. Our facilitator is going to organize those for the Q&A portion. And then closed captioning is available for anyone who needs it. You just simply click on the Show Captions button at any time to enable that feature. And before diving into today's topic, we're going to take just a couple moments to focus on the mission of NHTSA's Office of EMS. Our office supports the improvement of patient care in the out-of-hospital setting nationwide, and we do that in several ways. We bring together data and experts to identify critical issues in the EMS field. We collaborate with our partners. This is huge, a lot of collaboration, including federal agencies and national organizations, and we address those issues that way. And then promoting awareness and education and best practices and evidence-based guidelines. And one of the ways that we achieve our mission is by providing resources to help our EMS leaders and our clinicians. So the resources hub on ems.gov makes it really simple to browse and search and download a wide variety of documents and reports and guidelines. So take a look at that if you have not done so. These resources are created by NHTSA's Office of EMS and its partners, and this really helps us advance EMS practices. And then to access these resources, you can scan the QR code that's on the slide, or you can visit the homepage at ems.gov. I'll give you a second just in case anybody wants to snap that QR code. And if you need me to go back to anything with this code later, you can let us know as well. So we're going to turn our attention to the safe systems approach. And post-crash care is really a key component of this approach, and it's guided by 6 basic principles. The death and serious injuries are unacceptable. The aim here is to eliminate crashes that lead to death and serious injuries. And humans make mistakes. That's number 2. So mistakes are inevitable, but the system is designed, or that can be designed, to accommodate them and reduce harm. And that's what we're working towards. Humans are vulnerable, another principle. So systems should account for the physical limits of human tolerance in crashes. And responsibility for this is shared. So preventing fatalities that requires collaboration among all stakeholders involved. And then safety is proactive. So issues should be identified and addressed proactively rather than reactively. And then redundancy is crucial. Having a robust system ensures that everybody, that if one part fails, then others are still protecting people. So we're not going without with our redundancy. Okay, And it is now my pleasure to introduce our speakers for today's webinar. We are honored to have Dr. Bosson and Dr. Nutbeam with us. They bring a wealth of knowledge and experience to our discussion, and I am going to go ahead and turn this over to them. Thank you, doctors, for coming.
I think I'm first, so I'm going to advance to my slides. Good day, everyone. I'm Nicole Bosson. I'm the medical director for the Los Angeles County EMS agency, and I'm really happy to talk to you today about the National Association of EMS Physicians position statement and resource document on management of the entrapped patient. You can get a copy of the article I'm speaking about through this QR code. I definitely want to acknowledge all of my collaborators listed at the bottom here. This was a huge effort on everyone's parts, and I really appreciate all of them contributing, and especially Dr. John Ling, who has been leading the entire pre-hospital trauma compendium. So what is the NAEMSP Trauma Compendium? It is a group of related articles. It is 16 topics on pre-hospital trauma management. And the care of the entrapped patient is one of these topics. The way in which the compendium is being organized is the author groups develop PICO-style questions related to the topic, and this has driven systematic reviews of the literature to inform recommendations based on those key questions. The QR codes here take you to the introduction to the entire compendium, as well as the methodology that we used for each of these papers. So in terms of the entrapped patient, the reason that we wanted to include this as its own topic in the compendium is because entrapped patients are at higher risk of injury and death. And given the limited access and the prolonged scene time, their management is different than routine trauma care. And we do have specialty teams like urban search and rescue teams that specialize in response and extrication of patients who are entrapped. But the reality is that EMS clinicians encounter entrapped patients on a routine basis and need to have the knowledge and skills to manage these patients, especially in that early phase until those teams can arrive. Now, I want to frame this in that we are speaking in this manuscript on the totality of entrapped patients. So while motor vehicle accidents is one common way in which patients are entrapped, we are looking at this from all entrapped patients. So everything from collapsed structures, disaster events like earthquakes, industrial accidents, farming equipment accidents, and patients can be entombed, they can be crushed or entangled. And so all of these situations were addressed and considered as we made these recommendations. So our author group initially identified 5 PICO questions a priority. That was what initial assessment should be performed on the entrapped patient, what is the optimal fluid management for the entrapped patient, what is the optimal timing and frequency of medications for crush syndrome, should tourniquets be applied to crush limbs, and does physician care at the scene improve outcomes for entrapped patients? And as we performed our literature review, we identified 3 additional themes that drove an additional 3 questions. And those were what medical care, how does the medical care, integrate with rescue for the extrication of the entrapped victim? What additional interventions are essential for the entrapped patients with prolonged field time? And what is the best approach to airway management for the entrapped patient? So we performed our systematic review of the literature. Our search strategy is available within the manuscript. We identified over 750 initial manuscripts, including 3 from the gray literature, and ultimately excluded a number of papers based on several things. One, we only focused on papers that included medical care. So if the paper was entirely focused on extrication or rescue alone, or disaster response without addressing medical care, we did not include that because we were focused on medical questions. We also excluded anything that did not answer any of our PICO questions. as well as editorials and secondary reviews, things that were not primary literature. We ended up with 101 studies that informed one or more of our 8 topics. So what are our recommendations? First, for patient assessment, we recommend that EMS clinicians perform a timely and thorough primary and secondary assessment and reassessments in parallel with the dynamic extrication planning. And this environment may require adaptation of standard assessment techniques and devices. And the importance here is that we want the medical assessments to support the patient care as well as support the rescue and not hinder rescue. And I think we'll hear from our colleague here, Dr. Nutbeam, on how important it is to prioritize rapid extrication. And so this patient assessment needs to adapt and integrate into that and not hinder it. And we've made some recommendations within this document to that effect. And importantly, coordination and communication is huge, not just communication between rescuers or with the hospitals, but also communication with the patient. And I want to credit Dr. Nutbeam for this because a lot of his work has really informed this recommendation and really emphasized that EMS clinicians need to establish early, clear, and ongoing communications. And so not only with the rescue personnel to ensure coordinated, patient-centered, and medically directed approach, but also communication with the patient and be frequently in communication, clear, and reassuring with them. And so there's more information within our manuscript about the importance of these communications for the experience of the patient and also for the optimization of the extrication process. Hypothermia was a big theme amongst the articles that we reviewed. It was really emphasized that once hypothermia sets in, it is very challenging to reverse. And so taking early steps to mitigate hypothermia and prevent it from occurring is really important. And the other thing that was emphasized and captured here is that it's not just when it's obviously cold outside. Patients can become hypothermic given their entrapment exposure for a long time, even in ambient temperatures that seem relatively benign. In regards to airway management, I don't think I need to tell you that it is challenging in patients who are entrapped. And the literature was a bit mixed on how to mitigate the challenges, but what we've recommended is that when required, advanced airway placement should be performed by the most experienced operator with proficiency in multiple modalities and alternative techniques given the limited access situation. So thinking about your alternative techniques, whether it's supraglottic airways, lighted stylets, video laryngoscopy, it will depend on the entrapment and the situation that patient, and you need to be facile with all of these techniques to optimize airway management. In regards to fluid resuscitation, I want to emphasize that our recommendation is specific to entrapped patients. There's an entire other trauma compendium article about fluid management in the trauma patient. This was specific to entrapped patients who are experiencing or at risk for Crust syndrome. And we recommend that EMS clinicians should initiate large volume fluid resuscitation in these patients, which equates to 1 to 1.5 liters per hour in adults. With crystalloid, and that's preferably normal saline without potassium, as early as possible, and importantly, prior to extrication. And again, this is for patients who are at significant risk for Crush syndrome, and the idea being that early initiation of fluids reduces their risk of the acidemia as well as renal failure that can lead to poor outcomes in these patients. We also looked at what medications should be administered for crush treatment, and I will say that there is quite a dearth of literature. There's no studies actually looking at the exact timing or the efficacy of these medications, but there is a lot of support for administration of medications in patients at risk for crush syndrome to prevent the concern for cardiovascular collapse upon extrication, as well as later renal issues. So we recommend that EMS clinicians should administer medications to mitigate the risk of hyperkalemia, infection, and renal failure early and prior to extrication. And again, emphasizing that these are patients who are actually at risk for crush syndrome, which means they've been entrapped for a significant amount of time. We state in our recommendation that it's at least 1 hour, but that also relates to the amount of crushed tissue, muscle mass involved, as well as the duration and the extent of the compression, all relating to how concerned the EMS clinician is for crush syndrome. As far as the recommendations, they're highlighted in yellow here. Sodium bicarbonate, calcium, either gluconide or chloride, depending on what's available to you, and albuterol should be administered to patients who are experiencing or at high risk for crush syndrome. If within scope of practice, insulin and dextrose may also be administered. Important to monitor that to cause no harm. What is not recommended is mannitol or K-oxalate in most cases. Those would be in rare circumstances of very prolonged care where additional monitoring can be administered. And for cases of prolonged entrapment, antibiotics are also recommended, and we've made some specific recommendations for those antibiotics here. And this table is available within the manuscript. So for tourniquet placement, this is highly controversial in the crushed patient. I think we all agree there's ample evidence that if a patient is hemorrhaging, we should apply a tourniquet. That is agreed upon. And patients who are entrapped are at risk for hemorrhage. But we also wanted to understand the role of the tourniquet for patients with potential crushed injury, especially if medications may be delayed. And what we recommended was that tourniquet application should be considered in the setting of a crushed extremity as a potential adjunct to medical optimization before extrication in some patients. And we recognize this is controversial. We get into the balance of the literature on this topic within the compendium. And we used some of the literature from, say, military and austere environments with prolonged tourniquet placement to help inform this recommendation, but recognize that the crushed limb is an already damaged limb, and it does complicate the decision to place a tourniquet. And finally, in regards to physician response, we recommend that patients with prolonged entrapment with potential severe injuries that require complex resuscitation may benefit from EMS physician management on the scene, and therefore EMS systems should consider an early EMS physician response to entrapped patients. So in terms of our key principles, these just summarize our recommendations that EMS clinicians should perform a timely assessment, establish clear communications and a patient-centered approach to the extrication, prevent hypothermia, recognize that airway management is challenging and optimize advanced airway management when it is needed, initiate early fluid resuscitation for crush syndrome, treat crush syndrome with medications when indicated prior to release of the patient, apply tourniquets in only select cases, and consider physician scene response in these cases. I am available for any questions after. We're going to take some here, but if you don't get a chance, this is my email, and please feel free to reach out, and I'd be happy to discuss more. Thank you very much, and I'm going to turn it over to Dr. Nutbeam for his presentation.
Now, I understand that it's been played automatically. If it's not, I can speak to slides, but I think it's pre-recorded. Here we go.
Hi there. My name's Tim Nutbeam. I'm a consultant in emergency medicine from the UK, and I also work in pre-hospital emergency medicine. I've worked in those environments for the last 20 or so years and have had an interest in extrication and motor vehicle collisions for the last 15 or so. I'm the research director for Impact, which is a research centre which focuses on post-collision care and how we offer our patients absolute optimal outcomes. I've been asked to come today to talk about extrication and how we optimize patient outcomes. We're going to be talking about a series of research papers that we've produced as part of a project called the EXIT project. So, what is the background for this? So in my role as an emergency medicine attending and pre-hospital emergency medicine attending, I saw this disconnect between what was occurring at the roadside, so prolonged extrications focused on absolute movement minimization, and the injuries that I was seeing my patients with in the emergency department and also succumbing to. And there seemed to be this mismatch between the time that we were spending on scene. We did a prospective piece of work in the UK and demonstrated that was a median of 32 minutes. And the rush to get patients to damage control surgery or to blood products or to other interventions when they came to the emergency department. And we decided to challenge this and try and do an evidence-based project around extrication. We use the lens of evidence-based medicine, and that's using a combination of scientific evidence and generating more if you need it, patients' values and preferences, so what do our casualties want and need, and also expert clinical judgment. And we use those three domains to map out our project. So we looked at the science for a systematic scoping review and then added our own bits where there was missing science. We interviewed patients who had undergone extrication, patients both with and without a spinal cord injury, and asked them about their experience. And then we've gone on to develop consensus and Delphi type guidance, and I'm going to show you the latest iteration of this at the end of these slides. This is the project mapped out in a slightly different way. You can see how it all ends up with consensus expert guidance. So we're going to quickly look at each aspect of this project. So a systematic scoping review. So this is where you go and you look at many, many records, and we looked about 7,000 records and could, as a result, track how the evolution of extrication has occurred through the decades, from the first vehicles, from the involvement of rescue services, the first roof-off type extrication, and the first tools being developed. And over time, you do see a change. We see a change from extrication being applied to just those who are anatomically trapped, to extrication being applied to those with a suspicious mechanism of injury. And we see more and more patients as a proportion of the total number of accidents being extricated as a result. The interesting thing is when you look back through these papers, there's never been a scientific evaluation of extrication or a test that it works or that it's proportionate. And it's really interesting to look at accidents which occurred before things such as seat belts, central safety zones, crumple zones, and those sorts of things. And it's fascinating to see the rate of spinal injury and spinal cord injury which occurs before this time. So what was our take-home messages from looking at these 7,000 papers? So we found that previous extrication strategies do not have a scientific basis, and therefore we needed to do some work to help provide that scientific basis. And as a result of that, we move on to the first 3 of our publications. We need to work on developing that primary literature. So first publication, these are all free and open access, so you can have a look at them yourselves. But all of these papers look at the UK-based Trauma Audit Research Network data. This is from all major trauma centres in the UK, and we've got really good data capture. Essentially, the hospitals need to submit or they don't get paid, and that's a good driver for high quality data. And we looked at just over 60,000 road traffic collisions, and we found a big difference in mortality. So those were trapped, 8.9%, and those which weren't trapped, about half, around about 5%. Interestingly, being trapped was an independent risk factor for death. So this took into account age, sex, injuries, type of injuries, physiology, Charlson Comorbidity Index, all of the data that we had on these patients, and still being trapped was an independent predictor of death. We also found that when we looked at those patients who required an extrication, spinal cord injury was relatively low. I'm not at all saying it wasn't important, but it was about 0.7% of patients who we were extricating had a spinal cord injury. Of those patients with a spinal cord injury, more than half had another severe AIS greater than 3 time-dependent injury. Also, many patients look the same, and this is a finding that we can dig into more in the questions, but once you exclude patients who are obviously sick, so those who are unconscious or those without any pulses, and you have those who are injured, but you don't know who are sick and who aren't, actually clinical observations were a really poor discriminator to work out who was really sick, going to be dead within 24 hours, and those who are actually really quite well. So we do need to take that into context, the fidelity of our clinical examination with these patients. Study 2, so this looked at age, and we stratified patients by their age and then adjusted for confounders. And we found that those who were elderly were much more likely to die if they were trapped. And we found that if you were interested in self-extrication, so people getting themselves out the vehicle, then the propensity for this was going to be about the same across the decades of life. So older people should be offered self-extrication, and we'll come on to that in more detail later on, as well as younger people. There were differences, statistically significant differences in the frequency of things like chest injury and spinal cord injury, but they weren't significant enough to kind of dictate a change in practice. They were more statistically different rather than clinical difference in findings. Study 3, does biological sex matter? And we could spend a long time discussing this. So females, particularly younger females, were much more likely to be trapped. And we've got some follow-up work looking at that, trying to work out why that happened. There were different injury patterns, so the female sex pelvis does seem to be more likely to be injured, but they're also much more likely to have side impact collisions, so perhaps that's part of this picture. Females were also more likely to have spinal injuries, but once again with the mechanisms of injury, that might explain some of this, but we know that there are anatomical differences in terms of things like spinal ligamentous structures. So some take-home messages from this aspect of the work that we did. So we've already touched previous extrication strategies don't have a scientific basis. Trapped patients die more frequently. 0.7% of those patients who require extrication have a spinal cord injury, and of course the others are likely to have other significant injuries. Clinical observations can be and are falsely reassuring. Most patients do not have injuries which prevent self-extrication, and there are some differences between the ages and decades of life and biological sex, but probably not enough to dictate a different extrication strategy. This is a paper that has been submitted for publication in BMJ Public Health, and it looks at the ratio of spinal cord injuries across the world. And you can see that percentage of spinal cord injuries is roughly similar across the continents, regardless of types of vehicles, driving styles, all the other things, all the pillars which might affect road injury. And you can see that the highest rate of spinal cord injury is kind of 1.7, 1.8%, and the lowest is kind of, as we saw in the UK, around about 0.7%. But across motor vehicle collisions with major injury, the rate of spinal cord injury is, whichever way you look at it, is relatively low. So we're going to move on to this next bit now, which looks at biomechanical analysis. So what we did here is that we studied healthy volunteers of different ages, males and females, different body mass indexes, and we extricated them again and again and again. And when you extricate enough people enough times, you can build up these 3D biomechanical models of a standardized extrication. And we looked at different extrication techniques. And then you can take measurements from these models. Here, I've shown you one method of capturing data. I think it's important to say at this stage that we looked at other methods of capturing data, and the result is consistent. Since our work as well, study groups in Spain, parts of South America, in all other parts of the world have done similar experiments and found very similar results. So what did we find? So, this is another example of an extrication using an IMU, and you can see this is a roof-off type extrication. So the patient has been rocked back, they've had a spinal board inserted beneath them, they get gently lifted up out of the footwell, and then they go out the back of the car, and then finally at the end of the extrication, the board gets laid down. Clearly we can't see the board in the car, so I apologise for that. But hopefully from this you can see how we could take measurements from the spine and then use those measurements for scientific purposes. So quickly looking at some of this work. So this one looks at the value of collars and instructions, and essentially collars do restrict movement. I know there's some controversy around collars at the moment, particularly in the UK, Europe, and in Australia, but they do restrict movement. Whether they restrict them by enough is a different matter. It's important to know that actually the process of applying a collar also causes quite a bit of movement. So if you're interested in total movement, which might contribute to spinal cord inflammation, then the total travel time is about the same whether you use a collar or not. Once again, we could dig into the weeds of this for a long time. We don't have time today. So I think this is one of the most important papers. We looked at the commonly used extrication methods in the UK, and I suspect there's some similarities between the methods which are used in the UK and the US, but the nomenclature may well be different. So we looked at roof-off type extrication, cutting through the A, B and C pillars, lifting the roof off and then taking the patients out on a board, normally rocking back the driver's seat. And we looked at a B-post RIP type extrication, so a lateral extrication process. And we looked at a rapid no-cut extrication technique where a patient was brought out of the driver's door onto a spinal board or a scoop type stretcher without the use of tools. So what did we find? So we found that all three extrication techniques performed very similarly from a scientific analysis perspective. And this was the same regardless of movement type that we looked at. So whether you looked at forward, backwards movement, whether you looked at yaw, whether you looked at rotation, this was a very similar finding. So roof-off extrication, which in the UK takes about 32 minutes, performed the same as a B-post RIP in terms of spinal movement, which performed the same as rapid extrication. And rapid extrication we know we can do in a couple of minutes compared to 30 minutes. And that's a long time if you're bleeding to death. So this really turns our extrication practice on its head. So we thought, starting this project, that roof-off extrication was slow and gentle, and as a result would lead to minimal spinal movement. That isn't the case. It causes about the same amount of spinal movement as rapid extrication. Very interestingly, and again a very consistent result across our experiments and those of others, self-extrication causes less than half the movement at the C-spine or the lumbar spine compared to the formal extrication techniques. We also looked at chain cabling, which is a Scandinavian technique. I'm not sure it's used in the US very much outside of heavy vehicle rescue, but you can have a look at this paper if it's relevant to your practice. So some additional take-home messages. Collars do reduce movement during extrication, but the clinical importance is unclear. Self-extrication consistently produces less spinal movement than other extrication techniques, and all other extrication techniques produce statistically similar results. So we then moved on to ask patients what they wanted from extrication, and we interviewed those with and without a spinal cord injury. I expected this to be about pain, temperature, noise, but it wasn't. It was about communication and companionship. Please hold your patient's hand explain what's going on, tell them what's going on throughout the extrication process, and they will have a much better experience. Don't treat them like a sack of potatoes, treat them like a human being, and they will thank you for it. And it's very likely, we're doing some follow-up work, that as a result they will have better return to work, less PTSD, a much better experience at 6 months down the line. So take-home messages: patients value communication and a dedicated extrication body. Finally, study 9, lots and lots to cover here, but this was a Delphi type technique, so a consensus finding technique, asking experts in fire and rescue and clinical care in the UK. And between us, we realised some themes. Once again, this is free and open access. I encourage you to go and have a look at it. 92 statements, which were condensed into a series of statements which were adopted by our UK Rescue Organisation, our National Fire Chiefs Council, our JRCALC, who set the standards for paramedics, our College of Paramedics, the Faculty of Pre-Hospital Emergency Care, so widely accepted across the board. We developed some tools to help people with this. So this is the You Step Out tool. We've not got time to delve into it now, but hopefully during questions we can spend a bit of time on this. But this is designed for non-clinicians to risk stratify patients to see who can step out of the car, perhaps following a release, rather than coming out through a formal extrication process. We came up with an extrication decision tool which prioritised casualty self-extrication above other methods of extrication. And we've come up with some new Faculty of Pre-Hospital Emergency Care guidance, which has been released just in the last few weeks. This prioritises a focus on time rather than a focus on absolutely minimising movements. It empowers fire and rescue services to make decisions around extrication technique prior to clinician arrival. It focuses on enabling self-extrication. It also takes away from some of the manual inline stabilisation that we've done historically and says for fully conscious patients without neurology that's not relevant or required. And it talks about how patients who do have neurology are time critical and need to come out quickly. It talks about vehicle relocation, which I know is done in some parts of the States, and that rescuers should be aware that clinical observations prolong entrapment time and are a poor predictor of patient outcome. Also focuses on minimising the clinical care, just the critical interventions to expedite safe extrication. We've moved away from applying pelvic binders in the car, that's now contraindicated, and we need to focus on psychological impact of extrications and body care. We also talked about the value of regular joint multidisciplinary training, learning, sharing, and case review. So that brings me towards the end of our talk, Sorry I couldn't be there myself today. Rob is available to take some questions. I hope this has been useful to you. Please do visit us at www.postcollision.com. We would very much like to know about your projects. We'd very much like to help. We see ourselves as an enabler of joined up research in this area. We would do welcome any questions. Thank you very much.
Thank you, Dr. Bosson and Dr. Nutbeam. That was some really great information. I know we have a lot of questions that are coming in on the chat, which is fantastic. Many of them, I know you've gotten to answer some already, but I will go ahead and just read a couple of them out here that if we don't have time to get to everything today, just so everyone is aware, we will compile a document with responses and share it along with the archived recordings of today's session. So you will have access to those. So let's see, first one here, Dr. Bosson. Looks like from Megan, she wants to find out if there is no medication at the time of the incident, what are possible alternatives during entrapment?
Thanks for that question. So I do want to emphasize that the evidence behind administration of the medications that we've recommended is pretty minimal. While authors pretty much universally agree that these medications should be administered to patients with crush, and we're really talking about patients who are crushed, right? So we've defined that as at least 1 hour with a significant muscle mass involved. I think most of you know, to recognize those patients. Most authors recommend the use of these medications due to anecdotal, patients extricated and died, right? We know that they can have cardiovascular collapse, severe dysrhythmias, acidemia, and go on to have renal failure. And these have been described in numerous situations, especially coming out of major disasters. So that's what's driven this recommendation. And if you look across organizations such as INSEROG, so I'm coming from this perspective of a USAR doc, right? So I work for California Task Force 2, USA 2, the USAR team. And our international organization, the International Search and Rescue Advisory Group, strongly recommends, treatment of these of crush to prevent extrication, to prevent cardiovascular collapse after extrication. And we're talking about patients that have been trapped for some significant amount of time. So it's going to depend on the circumstances that you're encountering this patient, and if they have crush. And if they've been entrapped for a significant amount of time and at least 1 hour and muscle mass is involved. If so, we do recommend getting those medications there and thinking about how you can forward deploy resources to treat the patient and support them during the extrication process. If you can get them out quick, I think Dr. NAEMSP made a great case for just get them out quick, right? And then you won't have to worry about this. What if you don't have medications? Well, that's a challenge, right? Fluids definitely help, right? Fluids and early fluids. And I love, we got a lot of questions about blood in the chat. And I'm sorry I didn't mention that before, but there's a separate compendium manuscript about blood and really addressing that. We simply acknowledge that, blood is, if available, is important for any patient with hemorrhagic shock. But when we're treating crush, fluids are helpful. And early. So that may be something you can administer. There've been a lot of questions about albuterol. So maybe you can't place an IV and administer IV medications, but your BLS service, albuterol can mitigate hyperkalemia through shifting that potassium into the cells, at least temporarily help. It is higher dose than you're typically using for your wheezing patients and would be fairly continuous. And of course, in a confined space, you have to think about how you deliver that albuterol, whether you want to oxygenate the environment, which could be combustible, or use, say, an MDI and spacer, which is how we approach it frequently in the USAR space, given the confined space environment. Other than that, really great questions about what else people can do. Mitigating hypothermia does not take, anything fancy. So blankets and windshields, performing that assessment and identifying that patient who's at higher risk can be done without those medications, controlling bleeding and supporting the patient's airway and preventing airway compromise. Certainly in some environments, it's less of a concern, but we definitely worry about that when there's dust and debris in the environment, and actually protecting the airway with masking can prevent, say, a future need to intervene on those patients. So broadening the question a bit, but thinking about what can you do if you don't have those ALS abilities to administer the medications. And as I mentioned before, tourniquets, highly controversial. It's something to consider if you have severe crushed limb and you are very, concerned that that patient is going to have a large bolus of toxins as they are extricated, and you reperfuse that limb. Consideration for tourniquet placement to sequester the injured tissue until you can do a controlled release is something that could be considered. And I'll leave it there. And if that triggers other questions, I'm happy to take them.
Thank you, Dr. Bosson. Switching over to Dr. Nutbeam, we actually have a question for you, or multiple questions for both of you. For Dr. Nutbeam from Joshua Mastenbrook, any data on the difference in vehicle type, for example, pickup truck versus car, and their association with entrapment?
So Hi, folks. Sorry for sorry for the terrible audio of my recording. We recorded it in advance, expecting terrible audio, but I think it's probably better over this form. Thank you very much for inviting me this evening. I've got to point out that I'm not an engineer, so I'm primarily a clinician and a researcher. I think your question is primarily about physics and materials, and we do see big different when you see differences between the strength of materials and momentum associated with the crash, so kinematics, velocity and weight between the vehicles, you will see the rate of entrapment go up significantly. So modern vehicles with vehicles manufactured in the last 10 years tend to be structurally very strong. But if you put them up against a heavy vehicle, for example, a heavy goods vehicle or a large pickup with a full load, then you'll see significant exchange of forces. So in summary, it's all about engineering and physics rather than clinical care. But when you have differences between the vehicles, where you'll see the highest rate of entrapment.
Great, thank you. Staying with you, Dr. Nutbeam, did you feel that age, gender, and other demographic factors influence injury patterns and outcomes?
Yes, definitely. So there's a big difference between patterns and outcomes. So generally, the differences that we see in injury patterns are statistically significant differences rather than clinically important differences. So there are small differences in the rates between females and males. Females are slightly more likely to get spinal injuries, but it's not good. The difference isn't so much that it's going to make a difference to your extrication strategy. When it comes to outcomes, there's huge differences depending on both sex and also particularly on age. And some of that is interaction between treatment, car design, approach, historic health inequalities, many things interacting with that. The biggest predictor of a poor outcome following a motor vehicle collision is patient age.
Well, staying with the spinal cords for Dr. Nutbeam, what is the evidence that spine boards prevent or treat injury?
So they definitely don't treat injury. They're not a mechanism of treatment. And from my perspective, there is very little evidence that they reduce or prevent injury. There is a very recent systematic scoping review which has been published, which looks at pre-hospital immobilization in general. And the benefit of pre-hospital immobilization cannot be defined. If you look at international extrication practices, so spinal boards have pretty much gone in the UK and most of Scandinavia. We're using scoops far more commonly. Collars have completely gone in the Scandinavian countries, and from Western Australia, hard collars have been replaced with soft collars. Most of Europe have moved away quite strongly from using collars routinely, only using them on selected cases. So yeah, there's definitely big international differences in our approach to immobilization. We think, from what we've understand from our biomechanical evidence, that a gentle patient handling approach is the way to go. But if a patient does have a definite spinal cord injury, then they need particularly gentle handling. But most of them will have another time-dependent injury which prevents them from looking after their spinal cord. So by the time you've had the transfer of energy to give you a spinal cord injury, you've normally got an associated head injury, chest injury, and abdominal injury, which prevents spinal cord perfusion or causes spinal cord hypoxia. So we need to balance this very carefully. So we know that slow and steady doesn't do the job. So slow and steady is just slow. It's not slow and steady. So gentle patient handling, but with a focus on timely extrication is the way forwards for these patients.
And then a follow-up question for Dr. Bosson. Can you please elaborate on the dose of sodium bicarbonate, including push and infusion?
That I wasn't quick enough. I got that one in the chat, so I will say it out loud too. We do address this in the discussion. We recommend an initial push of sodium bicarb along with the calcium and the albuterol prior to extrication. Again, in these situations, we're talking about someone who's been entrapped for some time, right? And so administering that prior to extrication, and then if patients are prolonged entrapment, authors do generally recommend that bicarbonate drip to alkalize the urine and provide some renal protection. Some debate there, in terms of the actual effectiveness of that, but I would say across the literature, that is still recommended at a target urine pH of 6.5. And we detail that in terms of how that could be administered for a prolonged entrapment with a bicarbonate drip. And I also posted the specific language into the Q&A for those that want to read more about it.
Great,
Can I just, I think Dr. Boston's guidance is it applies to a far wider group of patients than specifically vehicle extrication that we're talking about, and I think from my understanding of the patients, particularly from the UK, who have vehicle extrication, the rate of them which have genuine cross injury with hyperkalemia, changes in pH, and all the things that we're talking about is extremely low. And when we try and replicate cross injury, vehicle cross injury in the lab, in the animal lab, we really struggle to do it, because you need to crush tissue for so long and so much tissue to get these changes in pH that we're talking about here. So I think it's a very different situation from building entrapment and prolonged crush, where people are trapped for hours and they've got big coverage. If you're just trapped by a small part of your body, even if it's for an extended period of time, you won't get these potassium shifts and the cellular destruction that we're talking about here. So in the UK, we've taken a completely different route, and we don't recommend any of those treatments for cross injury in the setting of vehicle entrapment, because we believe the harm in waiting for them outweighs any benefit, which is the focus on absolutely minimizing that entrapment time. So I'm sure there are some special circumstances in vehicle entrapment when all those medicines are necessary, but I'm a very simple emergency physician, and I like to do a few things well. I hope that doesn't. I hope you're in agreement with that, Dr. Boston, rather than see that as an interruption.
Absolutely. No, I'm glad you re-emphasized that, because at the very beginning, I wanted to say our recommendations are based on the totality of entrapment. And this includes disaster situations, earthquakes, patients who are entrapped for days. In our LA County system, we do have a crush management protocol. We do not exclude patients who are in motor vehicle collisions from this, but I will say in my time here, 12 years in LA County, I know of less than a handful of cases where it was clearly demonstrated. There are those cases, but clearly demonstrated that a patient entrapped in a motor vehicle benefited from the management of crush syndrome. They do exist, but it is not the most common. And so balancing, right, getting that patient out quick if you can. This recommendation of a bicarbonate drip and testing the pH of a urine is definitely for a patient you're managing over hours to days, not 30 minutes, which would be the typical extrication for a motor vehicle collision. Thank you for reemphasizing that.
Thank you. And thank you everyone for your questions. Thank you, Dr. Boston and Dr. Nutbeam, for presenting with us today. I know there's still a lot of questions to get to. Dr. Boston, you are a rock star going through those in the chat, so thank you for that. But anyone else, just again, as a reminder, if we did not get to your question today, then we will compile that document with the responses, and it will be in the archived recording for today's session. So thank you all for attending today's EMS Focus webinar. We do appreciate your engagement and hope that you did find the session valuable. Again, please keep an eye out for the recording and any additional resources, as they will be added to ems.gov. So thank you, everyone. Have a wonderful day.